My name is Terence Reed. I'm from Black Country ICEB. In today's podcast, which is the first of maybe a number of podcasts, we'll look to see how we go with that. We're looking at effective supervision and social prescribing. Our guests today are Anna. If you want to introduce yourself.
Hi, I'm Anna. I'm a listening and guidance social prescribing team lead in Dudley, and I also do a few hours a week for the Black Country Training Hub in personalised care facilitation, so looking after our social prescribers, health and wellbeing coaches, and care coordinators.
Wonderful, thank you. And Charlene?
Yeah, so I'm Charlene. I'm a social prescriber in the North Walsall PCN, and I am a senior social prescriber for North, East 1 and South 2 as well. So I deliver the service as well as supporting team members from other areas within their role.
Wonderful. Welcome to the first podcast. So I'm going to start off probably by explaining a little bit about why we're doing this podcast today. There's probably a number of reasons. First one being we commissioned a survey probably about 4 months ago, which was sent out to different social prescribing schemes to each place in the Black Country, asking them different questions about a number of different things around personalised care. One of them was around social prescribing. One of the themes that came back from each place, I don't think there are any exclusions, was around the need to have I suppose, a greater level of equity in terms of understanding and reduce variation around how or what effective supervision might look like in each place, because there are different models of it, and I think it means different things to different people. Some of that variation is completely warranted. Some of it might not be. So that was the first reason. The second reason is we have the integrated care strategy, which was published in January. And in that, we made a commitment to make sure that for any kind of intervention that involves some form of behaviour change, whether that be weight management, whether it be tobacco dependence, or whether it be anything around supporting the wider determinants of health, which is what social prescribing focuses on, that we found opportunities to provide support and try and achieve some sort of equity for that across the Black Country. And then the third one was in response to the findings from the report from the, if I get it right, National Association of Link Workers. I think that's the right one. They had 6 key messages that came out, and one of them was around making sure that we did all we can to support link workers to build on the amazing things they've done already over the last 6-7 years, or longer than that if you've worked in roles similar to social prescribing that aren't labelled as that. And to ensure they've got the appropriate training and development in place as well. So yeah, this is more like a kind of educational session, I suppose, targeted for anyone who's working in a social prescribing role, but especially for people who are looking to effectively supervise those roles. So I'm going to pipe down for a bit. I'm going to give you, Charlie, and you, Anna, I suppose a bit of an opportunity to explain what the context is around in the build up to that. So I'll open up the floor if you want to sort of describe that context.
Yeah,
Okay.
So just the context, the wider Black Country context that we've had over the past 3 years, I would say that social prescribers have particularly needed supervision. Now, this can come in all various forms. It can be one-to-one, it can be group, it can be peer supervision, it can be facilitated. And I know Charlene will later on speak around appraisals and that as a form of supervision. But the need to know, am I doing my job right within my context? And we know within social prescribing, there's so many different specialisms. Just within Dudley, where I am, there's migrant support, there's listening and guidance, looking at the emotional and spiritual needs, there's a frailty teams. And so, and then there's children and young people, which I think we'll talk about some of the studies from Wolverhampton Uni and how they're helping us at the moment, aren't they? And so as we look at the breadth of social prescribing, each individual therefore wanting to know, am I doing my job okay? I know we've got our line managers, we've got other supervisors, but in this open supervisory space, what is it that our social prescribers wanted to know? And it was very much the same as what our patients are, making every contact contact count, and it's what matters most to them. And so bringing together different groups of social prescribers to share what they're doing well, what the joys are, what the challenges are, how are they being released for supervision as well. I know over the years that NALW, National Association of Link Workers, has provided some supervision for some social prescribers, but it's been patchy. But what I think I can hear, Tez, from the survey, the ICS, and from the findings, is that there is scope to bring this together. So I think that gives a little bit of a backdrop, some of the story. Currently, myself and Joe, for the Black Country Training Club, are offering one-to-one and peer support groups, and that is a really safe space for social prescribers across whole of Black Country to share the joys, the challenge, the real disappointments when you've been working with a patient for so long and they just don't seek that behaviour change for themselves. But some of our social prescribers, I'd say, are the best of the best, desiring future hopes, dreams for these patients, whether or not they can see it for themselves, but it's working at the pace of the patient.
Wonderful. Many thanks, Anna. Charlene, what's your thoughts? I suppose when we talk about context, I suppose it depends on what your experience is. So from your experience, what's the kind of context we're working in right now around effective supervision?
So within the PCM, we talked about appraisal. So all social prescribers within our area will have a yearly appraisal that's done through Aranet, because most of us are subcontracted through Aranet, and that's delivered by one of the team leads from Aranet, manager or the line manager there. We then have our monthly, we class it as a team meeting, but we do an hour of peer support within that, because we have all social prescribers from the 7 PCNs in the area where I work all come together, and we'll do problem sharing, updates, discussions, and just sort of bring good ideas to the table to share together, as well as looking at difficult cases that we've had to work on, and seeing if anyone else could come up with a problem solution to that. From my conversations with the social prescribers in the Walsall PCN, there's a variety of ways that people are supported with the supervisions. So some PCN areas already have either monthly or quarterly supervisions that are taking place within their own PCN, and that's done through a lead. Other areas don't, so it's more ad hocly, asking for additional support as and when that comes up. So although it's not a planned supervision, there is that one-to-one support. It's usually a named person within the GP practice as well. So there's not always somebody that sits over the PCN. So I've got a collection of 10 GP practices, and I may have an issue in one that I wouldn't then go to a lead that covers all 10. I'd go directly to that one lead in that practice. So a lot of different varieties on supervision, peer support, and group work that goes on within the PCN. I think from our point of view, it's for those that are sort of ad hoc meetings, it's the recording, it's the sort of going back and finding that information, who was doing what, because the ad hoc meetings aren't generally recorded. Appraisals are. Appraisals look really well at staff health and well-being, how they're getting on in the role, anything that's difficult, anything they'd like to do more, training, educational, CPD. We unfortunately don't have the National Association of Link Workers contract under our service anymore. So we did utilise it when it was available. So we've lost that. So we're looking at new ways. I know that there's been a recent discussion, especially for the areas that I supervise, about bringing in monthly supervisions with staff. That's still in the sort of talking phase at the moment, so I'm just waiting for clarification on when that will happen. As I say, each PCN has their own sort of idea on supervision and how they want their staff to be supported.
Okay, cool. So before we I suppose did the session today, the podcast today, when I know we met briefly last week to plan what we wanted to cover, and we identified a number of key themes that I think we wanted to raised during the podcast that were based on both of your collective experiences and things that you've learned that were deemed as effective. I suppose before I do that, what's the risks faced with link workers if they don't have effective supervision? I suppose that's a good first one to look at. What's the risk that they might face?
I think one of the biggest risks can be burnout, feeling lack of support, not knowing where to go sometimes, or not having the confidence to approach people. Because obviously if you're not receiving regular supervision and don't feel confident in speaking to somebody about any concerns or worries that you have, then you hold all of that, and then that's where you lead to the burnout, high staff turnover because staff decide to leave. So there's a lot of additional problems that can come after from obviously staff not having those regular supervisions.
Okay.
There's also a space to think about the impact of their practice. If there isn't a space for regular supervision of whatever kind, we found that social prescribers would be more likely to work outside of their scope of practice, to work outside of what they're employed to do. Almost that I'll have to do it myself, I'll have to fix it myself, and that rescuer driver comes out. But when we're working together, there's that opportunity which bringing people together, reduces isolation, which is what we do for our patients, but when we're doing it for our staff too. And then there's that cohesive network of support that obviously is formalized in supervision, but also creates those peer relationships. Hey, what do you think about this? And just that regular check-in, maybe through a text or WhatsApp or through our NHS emails, but just that place where we can bounce things off one another, obviously held by a supervisor in a very safe and workable space, but that additional benefit really outweighs the risk of working outside the scope of practice.
Okay, so I'm going to try and pick off now, discussing each of the themes now. The first one came out, which I think, to be fair, I think we've explored already. So that was around about having structured support, and that's very, very person-centered, that obviously focuses on their well-being primarily, but also reflective practice and emotional resilience, and that it should be tailored to what their learning styles is. The second one that came up was around professional boundaries, role clarity. Should we unpick that a little bit more? What do we think that might mean in relation to professional boundaries and role clarity? Because I know this does come up quite a bit, doesn't it?
I think in terms of social prescribing, many of the workforce have come from other roles. It's quite a new career choice. I think from 2019 onwards, with the King's Fund development and everything else that's led on through that, especially working in COVID in quite isolated situations. But the professional boundaries and role clarity to me would mean how and what a link worker is supposed to do. And you've already heard me talk about the specialism, so I won't go back into that. But sometimes we can overlap or overstep with our health and wellbeing coaches or the care coordinators just sitting in those 3 personalised care roles, or get asked to do other jobs because of the needs and demands in practice. So I think what we mean by professional boundaries is looking at the workforce development plan and just checking, is this still something that we do? Why not? What's changed? And just coming back to the original or developed employment, but also just checking, are we doing something that's outside the scope? Is there training needs? I think we've already discussed on that. And what is it that link workers really support in practice? I think sometimes we can have referrals that are a bit ambiguous, but when we get to the heart of it, actually there really is a social prescribing need for that patient that can be worked with. So I think that's what, looking at the professional boundaries, just making sure we're not doing someone else's role, overstepping, and maintaining that professional conduct of, are we honouring our patients? Are we treating them with respect and dignity? Are we supporting their needs rather than what we want for each patient encounter?
Okay.
Similar for you, Charlene?
Yeah, very similar for us, and obviously working within the PCN, we may be asked to do some of the crop work. So if we are, the first thing we do is we make sure that there's no overall clinical element, or it's discussed that obviously any clinical elements cannot be supported through the social prescribers. So there may be large areas that we can cover, but then one thing within that discussion that we can't. For an example, if say we're going to do care reviews, there is a section in there that asks about medication, which obviously we wouldn't touch with a barge pole, but we can do all of the other questions because it's around the health and well-being of that carer. We tend to do the care reviews and similar things like that because we don't have care coordinators in my area. So I'm not saying that they're always done by social prescribers. Again, it's dependent on the PCN, but specifically for mine in the north, we do provide that support. So I work with each individual practice. So I ask us any question to do with a specific cohort of patients that is in need of support through the social prescribing service. We have that conversation, a very open conversation, and clear lines are drawn on what is within our work role and what is without our role, without our work role. So it's all very clear. There's nothing then that's missed, and we work in partnership. So once we've completed our section, that's sent back to the GP surgery, contactable person, whichever person's nominated to keep an eye on it, and then they will pick up the clinical elements of it, and that will get done that way. So that role defining is critical because, as a non-clinical staff member, I would never do anything that's classed as clinical, because it's not only unsafe for me, I'm not trying to do it, but it's also potentially unsafe for the patient that I'm supporting.
Okay, thank you. I want to swim over to the subject of being more outcome focused in evaluations. What do we think we mean by that, and how would that shape how effective supervision might, or what supervision might look and feel like if it were like outcome focused?
I mean, I don't know about Anna, but within ours, we do have, for our appraisals, we have set yearly targets that are written out in advance within the year. They can be added to and altered dependent if there's any changes within the work role or within the team size. So we have something to work towards. As I say, because different areas have different supervision models, some are reviewed more regularly than others. For myself, I do regular check-ins with the staff that I supervise to see how things are going. So that's the outcome. For us, we currently have no IIF targets that we used to use. So previously we had the IIF targets that we achieved on social prescribing under the DES and everything else that we worked towards. And we haven't had those for a couple of years now. So we use the original ones and we just show how we're still exceeding and how we're growing to show within our quarterly reports that social prescribing is still being used and is still an essential part to support patients within the practices.
Okay, thanks, Charlene. Anna, any thoughts?
Thanks. Yeah, loads of them on this one. So with our outcomes focused, can I just look on what our social prescribers' outcomes are in my team? Is that okay?
Yeah,
rather
sure,
than supervision
sure.
itself. Okay. So just to clarify that it's the outcomes would be looked at our social prescribers and their work with the patient. So often using ONS4, and the breakdown of that is just looking at life satisfaction, worthwhileness, happiness, anxiety. And with the ONS4, that's National Office for National Statistics. And that just captures different dimensions of a person and how they're doing. The limitation of that is it's very here and now. Somebody could have been feeling really wonderful, satisfied with life 2 weeks ago, but if something really severe happened, car broke down, running late, anything from the worst of the worst to just a minor upset, that can cause the outcomes to be skewed, as with any data analysis. So that there is that. But at times we've used the WEMWeb, so the Edinburgh Wellbeing Scores, and that's a lot of questions, 14 questions with a scaled score ranging from 0 to 7. And that gives a real depth of a person, but it does take a long time to go through. And sometimes sometimes it can feel quite, why are you asking me all of this? That's been some of our patient feedback. So just working within the ONS4 at the moment, there's obviously the friends and families outcomes that then get sent back to our ops teams, and they get to see what went well, what did they like about the service, what would they improve about the service, and would you recommend? Obviously a few more questions beside, but just looking at the impact measures, not every social prescriber completes them, and so there is some gappy data across the patch. And I know that Rachel Hopley over at the university in Wolverhampton, she's come up with the children and young people's outcomes framework, and I know that the Dudley CVS at least use the star analysis, the star shape, to look at the overall well-being of a person. As you can see, it's patchy, but there is a desire to see. When a patient started with a social prescriber, they were here, and now there's been a progressive impact. What I really like to see, I think it was again the King's Fund, that for every £1 invested in social prescribing, there's between a £2 and £9 economic value added, which would save money in the NHS. And so it's really hard to use just one measure to look at these outcomes, but supervision does have that space where we can look at the whole person, how we're doing as members of the workforce, and also the great impacts, which is so often stories, case studies, and not just numerical data and value.
Okay, excellent. Yeah, it does speak a lot to that 80-20 rule, isn't it? Like if you look at that 80-20 rule of, if you look at, I suppose, health outcomes overall, 80% of it is attributed to the wider determinants of stuff like how people behave at home and their environment and things like that. It's only a very, very small part that's attributed to if they were actually accessing care. It's only about 20% of that's attributed to when they actually access care. And I think that's why social prescribing probably plays quite a massive role in that, because it's very exclusively focused on the wider determinants of health. So yeah. So I'm going to swing over to a completely different subject now, around cultural competence. I think the reason why I think we wanted to speak about this was about we have a very, very diverse population. Some of the people that you will see, Anne and Charlene, are incredibly vulnerable. There's different cultural sensitivities at play here, and some of the groups that you'll see are quite marginalized as well. So if you think about supervision and cultural competence, what kind of things do you think come to mind, and what is it that, if you were undertaking supervisions, what kind of things that you think should be really, really important if you were leading on supervisions?
I think looking at our cultural biases and our unconscious biases is something that comes out in really good supervision. Looking at why, as an employee, why did I do that? Would there have been a better way? Did we give our patients time to tell their story so that we could respond in a way that meets their needs? And we'll know what we know. Charlene and I are very aware of that. We know what we know, and we're really aware of what we don't know as well. And so whether it is using Johari window and looking at blind spots and other forms and modes, there is a way, by working in a group, that together we can say, oh, did you notice? Did you know? But I'm curious about this. And as we're curious about one another, we then are able to reflect at the end of each session. I could have, and it's not always about doing it better, but doing our work differently, which means that those compassionate conversations that we have are tender-hearted, but not just because of who we are and what we know to date, but in listening, in sharing another's experience, walking in their journey. Obviously doing our own EDI training and looking at all the other elements that the Black Country ICB want us to be trained in, not just so that it's a tick box, but so that we can be the best workers we can to support our beautifully diverse populations. And it's very transient too. Many people will come into Birmingham and the wider Midlands and stay for quite a short period of time. So our work does have to be quite adaptive. I know here in Dudley, with a growing migrant community, there is some of our workers, they're like, I was doing such an excellent piece of work, would have had 8 to 10 sessions, but actually I've got to shorten that so that in 3-4 sessions before they're moved again to another location, they're able to do some real quality work with a person rather than leaving them not sure who would pick that up, but being able to support in the best way we can, knowing that we're supported and able to look at why we work in a certain way, why we chose this approach. And that means that our teams are safe, and it means that we're always learning from one another. And there is a wide variety and diversity in the teams who we lead and supervise, which is wonderful.
Cool.
Same for you, Charlie.
Yeah, I don't think I can add anything else on top of Anna's there. That was yes, very, very, very detailed and very much the same as what we do. You know, we do have the challenges, as you say, people moving in and out of the area, or a fast turnover for whatever reason. And it is about getting them the right support, and also having that support for the team members, because you know, some of the cases that we come across, especially when we're looking at the refugee migrant cases, there's a lot of quite detailed history that goes into that the social prescriber is taking on from an emotional point of view. So it's those debriefing conversations when we know that we're having the difficult conversations, the sharing of information that they've learned through supporting that particular patient, that we can share with the wider team in regards to cultural appropriateness as well. So yeah, just basically what Anna said, and a little bit extras.
Okay. So looking at the things we've discussed and identified to explore last week, the next thing that came up was around training and development. And I know that's a bit of a provocative question, because I think this is one of the issues that is highlighted nationally, is that there might be a little bit of a gap in terms of not just accredited supervision training, but I suppose the access to it. I suppose the question is then around what currently is there available if you were looking to have effective supervision. What's currently available by way of training? Is it accredited? And are there any kind of gaps and opportunities that need to be addressed in that space? I'll go, Charlene. Should we go with you this time?
The ones that I know of in regards to like the supervisions and that is usually for us under the online NHS training platform. Obviously, the Black Country Training Hub as well have got some sort of the mentoring training courses available. Accredited, I don't know if they fall under the accredited bracket, because they are usually day or a couple of days worth of training, and then you know, you do get a certificate, but it's not an accredited certificate that I'm aware of. And if Anna's aware of there being any particularly accredited for supervisors in a supervisory role, but there is quite a lot of mentoring and supervision based training. Not only there's some under the PCN that are done under a certain platform, and then there's obviously the NHS ones as well. We've done ones under Black Country Training Hub. I think it was through the Personalised Care Institute, if I remember correctly. Okay, But anything beyond that, I'm not aware of any accredited ones. So I'm not sure if Anna's aware of any accredited.
I reached out for my own. I paid for it myself because, and this is important, I think, because I saw the gap, and that was in 2023. And so because of that, I realised that to be effective in supervision, I needed to be trained. And so that was a personal investment in my future as well, and those who I lead. And when we're giving out these lead titles, I do see that there is some developments. There are some things in the background, as Charlene said, that there is accredited training coming. But what I think what we get to is we're not clinical staff. And so there's clinical supervision for clinicians, and then there's reflective supervision for social prescribers, and so it's just looking at that. But yeah, accredited supervision training would be a real gap in the market, and I can already think of about, you can probably too, maybe 10 to 15, Charlotte, people who would really be excellent supervisors to support the future in social prescribing.
So I'm going to I'm making an assumption here, and I stand to be corrected by both of you. So if we've got different models of supervision, so we've got things like peer supervision, clinical supervision, and I suppose managerial / leadership supervision, which so we've got, but that's the kind of one variable. But then we've got who's performing that supervision. So it might be a clinician who has, I suppose, less experience in the field of social prescribing, or I don't know, they might have had predominantly a career working in a kind of very, very clinical role, but a passion and interest in the wider service of health. Is there a little bit of a mismatch in terms of what the supervisor's primary role is and their experiences and their capacity to be able to deliver like successful supervision? Is that a bit of a mismatch? And I suppose, how do we overcome that if that is an issue?
I think there'd be elements of the role that would be difficult for someone who doesn't have a full understanding of the role to do. So, we've got the usual, your how are you feeling? That can be covered by anyone, because that's just you going through. It's when you get to break down the role itself, what support you're providing, how many cases you have, is it manageable? Because so you can't really put a point on how long that you first contact with the patient. You could have a quick 20-30 minute conversation. It could be an hour's conversation. You don't really know until you start that discussion. So there is that sort of mismatch of not understanding, because say you've got a clinical person doing your supervision and you tell them that you may have had an hour's consultation, where most clinicians' consultations are 10-20 minutes maximum. They get very well, why does it take that long? So that's where that mismatch of understanding our role comes into us, to try and explain that we need that time, one, to build up a rapport with the patient. A lot of the time patients don't know exactly what social prescribers do, so we have to spend a little time, and then once that person feels more comfortable, they then open up, and that's where the call can go to the error. So that's the one area I think that we do struggle when you are having supervisions. If it's a clinical staff member, it's the understanding of the time needed for our discussions. The rest of it is pretty bog standard for any sort of supervision, so the rest will come under a little bit of the training as well, because there isn't as much out there for social prescribers, or there's not a clear understanding of why we want to do a certain type of training. So clinicians, their pathways, any sort of clinician. With social prescribers, we've already gone in with quite high qualifications, so it's then getting them to understand why we want to do a next level or an on par qualification, so level 2, 3, 4, 5, whichever you hold as highest, trying to get them to understand you want to do a sidestep and do a social prescribing accredited training. They can't quite understand, because you already hold a qualification of that level. So it's that can be a little bit awkward within supervision. So I'd say those are the two barriers, but the rest of it is pretty much what you would do in any supervision. So the support will be there regardless. It's just two key areas that maybe need a little bit more of a pre-discussion or an understanding from the person who's going to be supervising you.
Okay.
Can I follow on from that and take us into the supervision models? Okay. I think, Charlene, what you say about not needing to explain your role to your supervisor is absolutely key. And so having our experienced social prescribers leading these sessions, it really is beneficial, or those who've worked with them or supported or received referrals from, is crucial, because who needs to explain what they do before they receive supervision. That is a wonderful idea there. And I think it should be a formative key. As we look at supervision models, there's three. And if you imagine it as a three-legged stool, you're able to see that these three elements make up a supervision model. There's the normative, formative, and restorative aspects. We've already touched on restorative, so I'll start there. That's just prevents staff burnout, and it really attends to their stress levels, their caseloads, their own well-being, and it really supports a person's resilience to continue working with patients despite deep trauma that might be released over the phone, over a video consult, or in a room or in a group setting, where some of our social prescribers do. Then there's the formative, and that's about opportunities for learning, opportunities to critically evaluate, what did I do? What could I have done better? Help me improve and develop. And as you said, Charlene, there's some real learning work that happens in those sessions. And then there's the normative. This is usually done by a line manager because it looks at professional standards, ethics, legal requirements. I love how we both say, if you were to say, do you do clinical work? No. I think, Charlene, you've said, I wouldn't touch it with a barge pole. And I love how colloquial that phrase is, because absolutely it's drilled into us. This is what we do, this is what we don't. But what supervision does is it touches that grey area, it's a little bit outside, but not fully. We could do it because I've had experience before. And that is that normative aspect of supervision, which looks at the performance management, quality control, and really lets our teams work safely and reflect safely, rather than, am I going to lose my job? Am I going to be performance managed? And so actually having these spaces for supervision where the supervisors are well trained, well led, well managed themselves, to offer that sounding board, and to carefully, obviously can take it out to the group as needed if it's safeguarding, ethics, outside scope of practice, but to have that first look. Sometimes I see supervision, and I know Hawkes looks at this model, but it's the many eyes model. And if you can just imagine lots of eyes looking onto a situation, oh, that's how we can really dig into it. There's other spaces in supervisory models, like Small World, using different, like Child's Play, you'd say, different shapes, different, if there's a patient that you're really struggling with, well, why? You've made them massive here, but let's just take it down to some Small World or Lego bricks, and let's recreate that. And so it's taking it away from another verbal discussion and using some quite interactive, imaginative play. If you've been in one of my supervisory sessions, I'll have got out the postcards and we lay them out on tables, and actually this is how I'm feeling right now. And sometimes it'll be like there's a big £5 note in the middle of one, and people just really need to discuss like how they're feeling when their patients are bringing something that triggers them in their own financial situation. Or another one, there's you'll know it, it's the Renaissance picture of the two hands pointing together and the hand reaching out, and some people are like, this is how I feel, but there's a big gap between me understanding what's going on with my patient. So yeah, within all of the management of it, the deep personal work, there's also touching on the triggers and how that patient really made me feel. I did my best professionally, but can we just really go there and talk about the corners of my life? And so it's just a really valued space for so many social prescribers there. Over to you, Tez.
I'm just thinking of I'm always trying to think of next steps, what to focus on next, and I'm thinking, but maybe there's an opportunity, and I probably need to explore it a bit more in a planning session around having some kind of model supervision session where people could dial in and watch what an effective supervision session which covers all those components. Because I know there's frameworks out there which are in documents, but then when you can read a document, but you're not really going to get a lot out of it until you watch something, reflect, and then have a chance to be able to go away and practice it yourself. It's like, I know, not those videos you get around coaching sessions. You can watch it, you can take a note of, right, okay, that's the framework I'm going to follow, but until you actually try it yourself, it's not. It's quite passive, isn't it? To just read it in a document and then just watch it. Whereas until you're actually trying it yourself, so maybe that's something that we could explore after the podcast, where we could look at some actual live
Lives.
examples. If someone wanted to agree to do it, we'll have to obviously explore the ethics around that.
Mm.
The other thing as well, I can't help but think, and this isn't on the script, so I'm going to go slightly off script because it's based on something that's been brought up. I suppose it's around those triggers. And one of the things that comes to mind is that our clinical and our medical staff, they probably face like personal triggers every day when they talk to their patients, and they might not have a lot of time to process that because they just crack onto the next sort of patient. And then actually, there's something that they'll share with their fellow social prescribing link workers, where link workers will have a bit more time because it's a very personalised role. But I suppose what I'm getting at is that they're both triggered in some way by exploring something that the patient's telling them. And that's the one common thing that's binding clinical roles and the social prescribers together, is that they both are every day faced with those triggers, and they've got different means to cope with them. And maybe that's the common denominator, that if they share that, then that's the common thing that could bind them together and help them support each other and understand what each other does. And maybe that's one. Maybe that's an opportunity for them growing and understanding each other's role more, I suppose. Yeah. I've looked at the hymn sheet, as I call it. I'm not going to call it a hymn sheet. I can't think of what else to call it. There's no of the themes that unless there's anything else at all that you think we've not mentioned. Anything else that comes to mind?
That I can think of.
Good.
We're good, yeah. Okay. I want to thank you both so much for your time. It's the first time we've done this, and it looks like there's a few things that we've identified that I don't think we expected that can be explored later on. So I want to thank you both for your time. Once we've published this, we'll come together and we'll try and explore some other things that we want to go through as well. But I'd encourage anyone watching this, please do share it with colleagues, not just across the Black Country, but wider than that as well. Please give people a nudge. Keep talking about it. Would love to hear what your stories are around that. If there's anything else that's come up within your careers that you think would add to the conversation and to the narrative, we'd really love to hear from you. We'll be publishing this on YouTube, so yeah, if you want to put comments in that and subscribe to the conversation as well, and to add to that, we really would love to hear what you've got to say about that. But yeah, in the meantime, thanks very much, Anna, and thank you very much, Charlene. Cheers.
Okay.
Cheers all. Take care. See you soon.
Bye bye.